So let's continue on with our case discussion. After 6 months, our patient, again, at this point, he has undergone radical prostatectomy, had adjuvant radiotherapy, gets started on continuous androgen deprivation therapy of depoluprolide every 4 months. He's on bone targeting therapy. He's on calcium, vitamin D. So at this point, his PSA had gone to 0.4 nanograms per ml. He was followed diligently by the urologist every 4 months, getting his PSAs checked, getting his lab checked. So at age 69, his PSA starts to go up again and goes to 1.4 nanograms per ml. Then 8 months later, it is 2.8 nanograms per ml. At that point, his treating urologist chose to restage him with bone scan and CT. And CT imaging shows a 1.5 centimeter enlarged pelvic lymph node and a positive bone scan showing 3 areas to the thoracic and lumbar spine. The patient still is very functional, asymptomatic. So at this point, Larry?
Well,
where do we stand? What's his status? How do you manage these patients at this point?
Well, I think that, you know, first thing I do is look at what's approved in this space. And, but I think that this would be a perfect candidate, he would be, for immunotherapy. And I think the earlier you start immunotherapy, the better. You get that on board, have it working, and then you can move on to your other therapies. But I think that I would consider Sapulus LT for this patient. He is minimally symptomatic or asymptomatic. He has bone mets. And I think it's really too early to start anything like chemotherapy because he really doesn't have really very many symptoms. So I think the CYP-T would be a good choice. And I think that just looking at the quartile data that came out and was published last summer in 2012, we're finding that the sooner you use the CYP-T and if their PSAs are lower than, let's say, 22, that those patients are going to live longer than those who have a higher PSA, let's say above 100.
Rather dramatically so. In that particular study, it was like 400% longer than the patients that were treated with PSAs above 50. I remember that was.
So as we all know, the initial bifurcation, obviously when they're diagnosed with CRPCM1 disease, we want them to maintain castration levels of testosterone. We would like them to be on bone targeting therapy. But that initial break point is whether they're symptomatic or asymptomatic. In the patient that is asymptomatic or minimally symptomatic, then the current recommendation with Category 1 evidence is really Sapulus LT or Provenge, as well as abiraterone or Zytiga, which was obviously recently approved based upon the Cougar 302 trial in December of 2012. Lenny, anything to add to what Dr. Karshan mentioned in terms of CYP-T, how you look at CYP-T, ABI, those types of things in this patient?
So I would almost roll back to one concept that I think we assume everybody's going to be castrate in this particular setting with this gentleman having a rising PSA. And again, I think this is something we really are getting more sensitive to, that we really do need to be checking testosterone levels on these gentlemen. And I think this is something that medical oncologists are probably more familiar with checking a lot of labs. I don't think a lot of urologists really follow the package inserts and are checking PSAs periodically. So I think, or excuse me, testosterone levels when they check a PSA. I think it's very important we assure ourselves this man has a castrate level of a testosterone before we move him ahead to these other treatments. But clearly, if you're going to use Sapulus LT, as Larry suggested, we've got to use it early, got to use it when the patient is minimally symptomatic or asymptomatic. Immunotherapies we know work in general when there's lower tumor volumes, and although the NCCN guidelines do include such items as Sapulus LT later in the course of the disease, if you're going to probably give the patient the best benefit, as has been noted with the quartile data, PSAs of less than 22, you go from a survival or a median survival from about 13 months to as short as 2.8 months of those patients who have really high PSAs. For the purposes of that study, you're talking about PSAs over 130. So all the data very strongly suggests if you're going to use sipuleucel T, use it early when the patient is minimally symptomatic or asymptomatic.
When was the last time you did a bilateral orchiectomy, just out of curiosity?
We actually oddly have one scheduled in 2 weeks for a man that we're going to have to do some work on who is resistant to all LHRH analogs. Never seen it. Funny that you ask it, but this man, we've had him on all of the standard, including the LHRH antagonists, and we cannot get his testosterone down. It's going to be a curious case study, but I'm going to be doing one. It's been a while, but we're going to be doing one soon.
And you would think with all the cost pressures that are coming to bear on the management of these patients, that it's compliant, it's inexpensive, and you know, it's something simple.
But it's not palatable to men, you know. I mean, that's why, you know, of course, it's obvious, and so that's why these other kinds of therapies took off. But I think it's you made a very important point, Len, and that is checking the testosterone levels. Because we do that routinely now in our castrate-resistant prostate cancer patients whenever we get a PSA. And I've been surprised, and especially in clinical trials, to see how many breakthroughs we get when we think these patients are castrate. And then just that case you just mentioned, that's very interesting because, you know, what do you do in that situation?
Yeah, we had a case like this some years ago, and it turned out he had a pituitary tumor, so definitely need to get a brain scan. The other interesting thing about this case is, which I don't think is common practice but needs to be, is that they did a bone scan when the PSA was only 2.8. And Evan has reported on some data on this, that if we look for metastases then, and document them with these scans, then we have the option of using an immune treatment at an early stage when the immune system is more intact and more robust, and the treatment is likely to be more effective. But unfortunately, and that when we didn't have a treatment, we really didn't even want to know about bone metastasis. Why dump negative news on our patients? But now that we have an intervention that prolongs survival, I think we need to change practice and start scanning people early.
And Mark, I would agree. I think that is a sea change that rapidly coming on board. I think the urology community, especially because a lot of these patients are housed under the urology umbrella. We have ushered them from diagnosis, definitive therapy, LHRH therapy, et cetera, and I think the concept now, which is really being driven home across the country, is go ahead, try to identify early for that exact reason. We know that there is no approved therapy in the M0 space except for observation in a clinical trial, and it's exactly like you said. If we can identify a MET, then absolutely we can get them on these therapies.
So I think it would be